My name is Nick Myerson. I am the lead colposcopist for Bradford Teaching Hospitals. I've been working in the department here for 17 years. I've been lead colposcopist for rather more than I care to think. And I also have outside that an involvement with the BSCCP.
So my name is Suzanne Taylor. I'm the lead nurse colposcopist here at Bradford Royal Infirmary and the cervical screening programme lead for the Trust. Here at Bradford Royal, we serve a diverse community of around 535,000 people. The community is quite mobile, and it's really important that when we come to colposcopy with an abnormal smear that we get it right for the patient first time.
At advanced colposcopy courses, which, because of my involvement with the BSCCP, I've attended a number. When we do case studies, there's a lot of debate and discussion when pictures go up of low-grade referrals and difficult to interpret pictures. The number of colposcopists who would immediately discharge, some would immediately biopsy, some would want to follow up. And it's not because people don't really know what they're doing, it's because the diagnosis is difficult. And although colposcopy may be a simple examination, it's a skill and it can be difficult to get right. And something like ZedScan has, my reading of the evidence says, been shown to improve the accuracy of the process, so it's got to be better and it's got to allow better decision making. I think on a very simple basis, if there's an additional technology that can improve the accuracy and the efficiency of what we're doing, then it has a value, and in many ways it doesn't need another justification. I think in terms of colposcopy, we are all aware of a potential bulge in numbers coming, so we do need to optimise the process that we deliver in an individual clinic. But furthermore, because we know that colposcopy itself is not 100% accurate, anything that can improve the individual's performance must be valued precisely because it will be improving the performance of the whole screening programme. Finally, if the concerns that colposcopy itself may become more difficult as HPV 16 and 18 are less and less of a factor in driving CIN, when one accepts the argument that they provide the most obvious changes at colposcopy, then having ZedScan or an adjunct technology is obviously important for the gynaecologist carrying out colposcopy or the nurse carrying out colposcopy, because it may help them overcome that particular difficulty.
ZedScan provides additional information following my colposcopy that will enable me to be confident that I have made the right diagnosis for the patient. ZedScan helps confirm the presence of high-grade disease if we're wanting to see and treat on the day, reducing the fear that we might be over-treating women, but also with low-grade and borderline smears, which can often be difficult to confirm presence of CIN. It helps detection certainly of high-grade lesions that you may otherwise have dismissed. So as a service, we're aware that with the introduction of primary HPV screening, that referrals are due to increase in the next 12 months. This could create capacity issues for our service and other services across the country. We need to be able to ascertain how we can manage these women more quickly and enable us to diagnose effectively and return to cervical screening confidently.
I think there are two benefits, or I'd characterise benefits in two ways. There are advantages for me and there are advantages for the patient, and as a clinician those are both important. For me, I find it very useful to both make a more accurate diagnosis, but also the localisation of likely change, the ability to identify the best areas to biopsy is very helpful. On the other side, getting a negative ZedScan reading is also quite helpful as a clinician, particularly given the number of patients we're looking to return to routine screening. Having that extra element of confidence is quite valuable. Well, one always must rely on oneself, obviously, and doing the right things, but the ZedScan helps with that. But also as a clinician, in terms of running the appointment, it's quite useful being able to show the handset to a patient, point out negative results, or point out why we're concerned, what these areas mean. I think helps explain the procedure, and that itself is an advantage for a patient. I think innovation is important and actually underrated in colposcopy. If I think of the colposcopy I'm doing now, the kit and what we're looking for and the way we do things is much the same as it was when I started doing colposcopy more years ago than I might care to remember. But we are aware of adjunct technologies that can improve the acuity of what we do. And we're fools if we don't value that and see that as a benefit. There are areas of research across a number of areas, including those of the outcomes of colposcopy, the outcome of treatment, which show that actually we need to be extremely careful about what we do and how we do it. I don't therefore think that expecting to do the same colposcopy that was being done 10 years ago and expecting better results in a changing clinical landscape is sensible, and therefore we need innovation.